Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
For everyone joining us today, and I'm talking to the surgeons, the anesthesiologists, all the medical professionals tuning in, we know that in the operating room, control is just everything.
Oh, absolutely.
Right. You expect predictability. You've got your monitors, your alarms, all your data streams. And for, the vast majority of your cases, a standard non-invasive blood pressure cuff, quietly inflating every 5 minutes, is really all the hemodynamic data you need.
Yeah, for most cases, for sure.
It's simple, it's non-invasive, and it just gets the job done.
Well, hold on. Before we dive too deeply into this, we really should state right up front that this content is strictly for reference only. You must always follow your local guidelines and, institutional protocols in your actual clinical practice.
Oh, yeah, 100%. Always stick to your local protocols. But, the reality of clinical practice is that you eventually hit those cases where that standard routine just totally falls apart.
It happens to all of us.
Right. Suddenly, that 5-minute interval between cuff inflations, it feels like an absolute eternity.
It really does.
The patient's physiological landscape gets super murky, and you realize you are, kind of flying blind.
Yeah, which is a terrifying feeling.
Exactly. So today we're taking a deep dive into the clinical indications for intraoperative arterial cannulation. We are unpacking those exact moments when a standard cuff just will not cut it, and why the decision to place an A-line, crossing that line from non-invasive simplicity to invasive precision, why that requires a really deliberate calculation of surgical demands, patient physiology, and absolute necessity.
Yeah, because when we evaluate that shift, from a non-invasive tool to a highly invasive one, it fundamentally comes down to precision versus simplicity.
Right.
The primary superpower of an arterial line, the feature that just completely separates it from a standard NIBP cuff, is continuous beat-to-beat hemodynamic monitoring.
Beat to beat.
Exactly.
Yeah.
You're moving from these sort of intermittent estimations to a continuous real-time physiological waveform.
So just to visualize that upgrade for a second, relying on a standard cuff is essentially like getting a still photograph of your patient's hemodynamic status every 5 minutes.
That's a great way to put it.
Like you see the snapshot, you assume everything between minute 1 and minute 4 was, relatively stable, and you just proceed.
Right. You assume nothing crazy happened in the dark.
Yeah. But an arterial line replaces those snapshots with a live, high-definition video feed.
And in a stable patient who's just undergoing a routine procedure, those 5-minute photographs are perfectly adequate, right? Because the underlying physiology isn't really shifting.
Sure.
But that live video feed becomes absolutely critical the second you introduce, say, potent vasoactive medications.
Huh.
When a patient is unstable and the anesthesia team is actively titrating vasopressors like norepinephrine or epinephrine, those medications are hitting the alpha-1 receptors in the vasculature in a matter of seconds.
Right, it's fast.
Very fast.
Yeah.
The systemic vascular resistance is changing instantly.
So if you're pushing like a micro dose of epi to support a crashing pressure, you can't just push the drug, hit the NIBP cycle button, and wait 45 seconds for the cuff to inflate.
Oh, absolutely not.
Because it has to measure the oscillations, deflate, and finally give you a number. You could be grossly undertreating a hypotensive crisis during that time.
Or causing a massive hypertensive spike that you won't even see until the next cycle.
Wow, yeah.
Exactly. In unstable patients, even incredibly short periods of undertreatment or, overtreatment, they have massive consequences.
Because the margins are just so tight.
Right. A transient drop in mean arterial pressure, if it goes below autoregulation thresholds, that can lead to acute kidney injury, myocardial ischemia, or cerebral hypoperfusion.
None of which you want.
Definitely not.
Yeah.
You need to see the exact moment the vasopressor takes effect on the waveform and the exact moment it starts wearing off.
Okay, let me push back on this just a bit.
Sir, go for it.
Because as clinicians, I feel like we're conditioned to just want more data. Like, more data on the monitors always feels safer to us.
Oh, it's a huge comfort blanket.
Right. So are there situations where we demand that live video feed just because it makes us feel more in control? Like, are we sometimes over-instrumenting patients simply because we like looking at the continuous waveform?
That is a very common trap. It really is.
Yeah.
Oh, for sure. The indication for that continuous feed is only truly justified when hemodynamics are inherently unstable or, when rapid, significant blood loss is expected.
Yeah.
You don't place an arterial line just to satisfy a desire for more numbers on a screen.
Right. It's not for our entertainment.
Exactly. You place it because the clinical scenario dictates that a 5-minute blind spot is actually physiologically dangerous.
Okay, got it.
If the patient is healthy and the procedure is routine, the extra data from an A-line isn't really guiding your management. It's just, exposing the patient to an unnecessary invasive procedure.
Okay, so if a standard cuff is taking those intermittent snapshots, we have to look at what happens when the camera itself just fails to operate correctly.
Yes, equipment failure is a huge factor.
Because we aren't just dealing with physiological blind spots, right? We deal with practical physical barriers in the operating room that render the cuff completely useless.
Yeah, the physical and technological limitations of the oscillometric cuff, those are major indications for moving to an arterial line.
Right.
A standard cuff measures the amplitude of pressure oscillations as it deflates. So it calculates the mean arterial pressure first, and then it derives the systolic and diastolic numbers through this algorithm.
Which is pretty clever, normally.
It is, but certain patient factors will just completely confound that algorithm.
Arrhythmias are a perfect example of this, right?
Oh, definitely. Yes. Specifically, atrial fibrillation or frequent premature ventricular contractions.
As the heart rate is all over the place.
Exactly. In AFib, the patient's RR interval is completely irregular, which means the ventricular filling time varies from beat to beat.
Right.
And if the filling time varies, the end diastolic volume varies, and therefore the stroke volume varies wildly with every single contraction.
And the cuff's algorithm simply cannot handle that.
Not at all.
Like, it's trying to measure consistent oscillations at different pressure steps to draw this neat little curve, but the heart is throwing out completely different stroke volumes every second.
Right, so the cuff just gets confused, it reinflates, it squeezes the patient's arm repeatedly.
Which patients hate, by the way.
Oh, they despise it. And eventually it just spits out a number that you can't even trust.
Yeah. And then beyond arrhythmias, you have things like severe peripheral edema or morbid obesity, right?
Yes. In morbidly obese patients, the geometry of the arm is often conical rather than cylindrical.
Oh, okay.
So a standard cuff just won't fit properly. The pressure transmission to the underlying artery becomes totally unequal, and the readings can be wildly inaccurate.
Wow. And then you have the external physical barriers, like the logistics of the operating room itself.
Positioning is huge.
Right. Think about a prolonged prone case, like a complex spinal fusion.
Yep.
Or a shoulder arthroscopy in the beach chair position. The patient's arms are tucked securely, they're heavily padded, and they're buried under all these thick, sterile surgical drapes.
Yeah, in those setups, your access to the arm is completely restricted.
Right.
If the cuff starts slipping or, if a kink in the tubing triggers one of those error messages.
Which always happens at the worst possible time.
Always. You physically cannot reach it without compromising the sterile field or totally disrupting the surgery.
So if you are the anesthesiologist sitting up at the head of the bed and you lose your blood pressure reading 30 minutes into a major prone spine case, you are in a terrible position.
It's a nightmare scenario.
So if you know going in that you won't be able to reach the arm, or if you suspect the patient's perfusion will make the cuff untrustworthy, should that immediately trigger a yes to an A-line? Does that lower your threshold right from the start?
It absolutely has to lower the threshold significantly. Inaccurate or impractical non-invasive monitoring is a fundamental indication. You simply cannot manage a patient's hemodynamics if you cannot measure them reliably.
You can't manage what you can't measure.
Exactly. If the physical setup of the surgery or the patient's body habitus makes the cuff untrustworthy, you just establish a reliable invasive data stream before the drapes ever go up.
Okay, so we've established the physical limitations of the cuff. Let's look at the internal environment. Even if a cuff could fit perfectly and you had complete access to the arm, what specific physiological states demand an arterial line?
This brings us to cases characterized by what we call physiological frailty.
Physiological frailty, I like that term.
Yeah, it's basically situations where the patient's compensatory mechanisms are already stretched to their absolute limit.
Okay.
So we are looking at severe valvular disease, significant heart failure, shock states, and sepsis.
To put that into perspective for the listeners, walking into the OR with a healthy patient is like walking on solid ground.
Right.
A photo every 5 minutes is fine because the ground isn't going anywhere. But managing a physiologically frail patient is like walking on thin ice.
That is a very accurate comparison.
You can't just guess your weight distribution every 5 minutes. You need to know exactly what is happening beneath your feet at every single second because, a tiny crack can turn into a total collapse instantly.
Yeah, let's apply that thin ice analogy to severe aortic stenosis, which is basically the classic example of this frailty.
Right. AS is notoriously tricky.
It is. In severe AS, the left ventricle is pumping against a fixed, highly calcified valve.
Okay.
So the stroke volume is essentially fixed. The patient's cardiac output is therefore highly dependent on maintaining an adequate heart rate and, critically, maintaining their systemic vascular resistance to ensure coronary perfusion.
Because if the afterload drops, say, from the vasodilation you get from just the induction of anesthesia, that thickened left ventricle can't just magically increase its stroke volume to compensate.
It cannot. It's anatomically incapable of doing so. So the blood pressure plummets. And when the aortic pressure drops, coronary perfusion pressure drops.
Which leads to ischemia.
Exactly. The left ventricle becomes ischemic, which immediately reduces its contractility, which then drops the blood pressure even further.
It's just this rapid, catastrophic downward spiral.
It really is. And in that scenario, waiting 3 minutes for a cuff to cycle is frankly indefensible.
You don't have 3 minutes.
You need the arterial line to see the pressure drop in real time so you can aggressively manage the systemic resistance with, say, phenylephrine before that ischemic spiral even starts.
That perfectly illustrates why patient physiology basically dictates the monitor.
Yeah.
But we also have to look at how the surgery itself impacts that physiology, right?
Right. The surgical stress is a huge variable.
Because major operations where rapid physiological shifts are just expected, like major abdominal, thoracic, trauma, and vascular procedures, they require that exact same level of vigilance.
Vascular procedures, particularly those involving the clamping of major vessels, are prime examples of this.
Oh, yeah.
Consider an open abdominal aortic aneurysm repair that requires an aortic cross-clamp.
The hemodynamics of a cross-clamp are honestly incredible to witness on a monitor.
It's wild. The moment the surgeon applies that clamp, the systemic vascular resistance changes instantly.
Because you're literally putting a wall in the artery.
You are suddenly blocking a massive portion of the arterial tree. So the left ventricle is hit with this massive, abrupt increase in afterload.
Right.
You see immediate, profound proximal hypertension, while everything distal to the clamp basically becomes ischemic.
And the anesthesia team has to respond immediately with vasodilators like nitroprusside or esmolol, just to protect the heart and the brain from that insane pressure spike.
Yes, and you can only titrate those fast-acting infusions safely if you are watching the pressure waveform beat by beat.
Right, because otherwise you might overshoot it.
Exactly. Furthermore, when the surgeon removes the clamp later on, the physiological shift reverses just as violently.
Oh, the unclamping shock.
Exactly. You have sudden, massive vasodilation from the reperfusion of all those ischemic tissues, a washout of metabolic acids, and just a profound drop in vascular resistance.
The blood pressure just completely plummets.
It bottoms out, which requires an instant switch from vasodilators back to vasopressors and massive fluid boluses. A non-invasive cuff simply cannot capture those immediate drastic shifts in vascular tone.
It's just too slow.
Yeah.
And it's also not just about reacting to broad systemic swings, is it? We also use these lines to achieve highly targeted pressure goals.
That's a great point, yes.
Like in neurosurgery, for instance, maintaining a strict cerebral perfusion pressure might be the literal difference between preserving brain tissue and causing irreversible ischemic damage.
Or in plastic surgery, managing the precise perfusion pressure required to keep a free tissue flap viable.
Right. You have to thread a very tight needle in those cases, and you just cannot do that with a blurry 5-minute snapshot.
Tight hemodynamic targets absolutely require continuous feedback. But, we also need to recognize that an arterial line is not merely a pressure sensor.
Okay.
It serves a secondary, and I would argue, equally critical function.
Right, because up to this point, we've talked almost exclusively about measuring pressure. But this catheter is literally sitting directly in the arterial blood flow.
Yes.
So it's a physical extraction point. It's like a high-speed data port straight to the lab.
It is. Frequent arterial blood gas analysis, or ABGs, is a major indication for cannulation.
Oh, for sure.
We see this requirement in patients with severe respiratory failure, profound acid-base disturbances, major electrolyte shifts, and, very notably, during massive transfusion protocols.
Yeah, when we talk about a massive transfusion protocol, the term monitoring tool almost feels completely inadequate.
It does, doesn't it?
Because in the chaos of a massive hemorrhage, You aren't just sitting back looking at the pressure waveform. You are drawing blood constantly.
You have to be. In a massive hemorrhage, you are rapidly infusing packed red blood cells, fresh frozen plasma, and platelets. You are actively trying to outpace the patient's blood loss while simultaneously battling the lethal triad of hypothermia, acidosis, and coagulopathy.
And you can't just guess where their coagulation factors or their electrolytes are at in that moment.
No, guessing will kill the patient.
Like, for instance, packed red blood cells are preserved with citrate, right?
Yes, exactly.
So when you pump units and units of blood into a patient rapidly, that massive citrate load actually chelates the patient's ionized calcium.
Which is absolutely devastating because ionized calcium is factor 4 in the coagulation cascade.
Oh, wow.
And it is absolutely essential for myocardial contractility. If their ionized calcium drops, their heart literally won't squeeze effectively and their blood won't clot.
So you have a patient who is bleeding out and going into heart failure at the same time.
Exactly. So you need to pull serial blood gases to constantly check that ionized calcium level along with their hemoglobin, their lactate to gauge tissue perfusion, and of course their acid-base status.
And without an arterial line in that scenario, what are the options? You're forced to perform repeated arterial or venous punctures on a patient who is actively bleeding and clamped down from hemorrhagic shock.
It's a complete nightmare.
Yeah, because the veins are collapsed, the pulses are weak, and you're losing precious minutes just trying to get a needle into a vessel to send a lab draw. You turn the patient into a literal pincushion.
The arterial line eliminates that delay entirely. It provides instant, reliable access to arterial blood.
Right.
In these high-stakes resuscitative settings, the line's function as a vascular access device for rapid serial sampling is honestly just as crucial to patient survival as its role in displaying the pressure waveform.
Okay, so the benefits are frankly overwhelming.
They are.
You have the live high-definition video feed of the hemodynamics. You have the high-speed data port for rapid lab sampling. You bypass the physical limitations of the cuff. And you can safely navigate immense physiological frailty and surgical stress.
It's an incredible tool.
So the obvious question has to be, why not just place an arterial line in every single patient that rolls into the operating room?
Because precision always comes with a physical cost to the patient.
Oh, there it is.
This is a surgeon's calculus. Risk versus reward. Placing an arterial line is an invasive procedure. You are introducing a plastic catheter straight through the intimal lining of an artery, and you're leaving it there.
And the vascular system generally does not like foreign bodies.
It really does not. The question for the surgical and anesthesia team is never simply, can we place an arterial line? The question is, does this specific case absolutely require moment-to-moment blood pressure control or frequent arterial sampling?
Right.
If the answer is no, then routine placement is just an unnecessary risk.
Let's talk about those risks for a minute, because they aren't trivial. Right.
No, they can be severe. The most common significant risk is arterial thrombosis.
Okay.
When you place a catheter into a vessel, particularly a smaller vessel like the radial artery, the catheter occupies a significant portion of the lumen.
It takes up space.
Right. The physical presence of the catheter, combined with the initial endothelial injury from the actual needle puncture, naturally promotes platelet aggregation and thrombus formation.
And if a thrombus totally occludes the radial artery, you're basically relying entirely on the ulnar artery and the collateral circulation of the palmar arch just to keep the hand perfused.
Exactly. And if that collateral flow is insufficient for any reason, the patient is at risk for severe digital ischemia and permanent tissue damage.
Which is a catastrophic complication for a routine surgery.
It's indefensible if the line wasn't indicated. You also have the risks of catheter-related bloodstream infections, bleeding, and pseudoaneurysm formation. When you weigh those real documented complications against a stable patient undergoing a routine procedure, the math is pretty clear. If the continuous waveform and the serial sampling aren't going to actively change your clinical management, the risks of thrombosis heavily outweigh the benefits of extra data.
It really synthesizes down to a core rule of thumb, doesn't it? We only graduate from the non-invasive cuff when the demands of the surgery, the vulnerability of the patient's physiology, or the absolute need for rapid blood sampling actually outgrow what that cuff can safely provide.
Beautifully said.
It all just comes down to precision versus simplicity.
Oh,
It is a deliberate, calculated escalation of your resources to match the actual threat level on the table.
It is. And when you look at the broader implications of all these clinical indications we've discussed today, it really forces you to think about the whole concept of trust in the operating room.
Trust. I like that.
Yeah.
Yeah.
We rely heavily on advanced technology, but that technology is completely inert without the clinical judgment wielding it.
Absolutely.
As the complexity of an operation scales up, our monitoring tools obviously must scale up to match it. But the true mark of mastery isn't just knowing how to expertly place the line.
Right.
It's knowing exactly when that boundary is crossed. It's knowing when the clinical picture demands that you abandon the simplicity of the cuff and embrace the invasive precision of the arterial line. Trusting your data ultimately means knowing exactly when you can no longer trust the cuff.
Wow. Knowing exactly when you can no longer trust the cuff. That is a fantastic, provocative principle to keep in mind the next time you're evaluating a complex case.
I hope it helps people rethink their approach.
I'm sure it will. Well, to all of you out there in the ORs, the ICUs, and the wards, thank you so much for joining us on this deep dive.
Thanks for listening, everyone.
If you found this content valuable, please do not forget to share it with at least one of your colleagues or friends to help spread the word.
Yeah.
We really rely on you to keep this medical community growing.
We really do.
Also, make sure to check out our YouTube and other social media pages for more clinical insights. And definitely check out our previous season and episodes. We have some very relevant topics waiting for you that you definitely won't want to miss. Until next time, trust your clinical judgment and stay sharp out there.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.